Thank you very much. Hello and welcome to this webinar about the difficult glaucomas. The term glaucoma itself is very difficult, so it doesn't need any more complexity. However, as glaucoma surgeons, we all meet difficult situations, very difficult glaucomas. And today we're going to explore some cases and discuss the management among us. And hopefully that will be useful for those who are practicing glaucoma. But Dr. Akhtas, Moustafa, can you unmute Dr. Akhtas, please? And I'm going to start. We're going to start with Dr. Karim Tomey. Dr. Karim Tomey doesn't need an introduction. He is my mentor in glaucoma, and he taught us quite a lot of wisdom, actually, and in the management of glaucoma and other things. So please, Dr. Karim Tomey, would you go ahead with your presentation?
Thank you, Moustafa. Can you all hear me well?
Yes. Yes, we can. Thank you.
Okay. I'm sharing my screen now. One second. Good evening or good morning, everybody, wherever you are. We have always wondered, especially as a tertiary care referral center, we get very difficult cases of glaucoma. What happens if nothing works? And we frequently encounter such cases. The purpose here is to discuss these difficult glaucoma cases that cannot be controlled even after having undergone multiple procedures. And without any further delay, I would just like to stimulate the discussion by presenting a case where nothing worked, actually, and finally something that we did not expect to work did work. This is a 55-year-old male who was first seen at the Beirut Eye Specialist Center in March of last year, and at the time he presented with something like conjunctivitis, and he had normal vision, and his pressure was well controlled on Cosap and Zalatan. He was a phakic patient with open angles and healthy looking discs. And then at some stage, the pressure went out of control and we could not control it by any means. And as this patient was living outside Lebanon and he was always eager to fly back to Africa, to the Ivory Coast, Ziad and I discussed it at length, and we decided to start with things that did not need really follow-up because he was not going to be under our eyes after the treatment. So a month later, we started by SLT in both eyes, did not work. Then we decided later to implant a valve in his left eye first. Again, the argument being that a valve does not require a lot of follow-up and he could probably travel soon after the surgery. And by the same argument, we decided to do GAT on the right eye. The left eye that had the valve went up again and we could not control it medically. So again, we tried something simple, needling of the capsule around the plate with mitomycin injection, did not work. And finally, we decided to go for the micropulse cyclophotocoagulation first on the left eye and then later on the right. Unfortunately, and I keep repeating myself, did not work. Pressures remained poorly controlled despite maximal treatment, including oral Diamox. So, what would you do next? I'm open to suggestions.
Well, I know how the case went, so I cannot I cannot give any suggestions. So what about Moustafa, Mohamed, Abdelhamid? Any suggestion where to take it after this?
You're talking about the left eye, which you have performed the valve for it, Dr. Karim.
Both eyes.
Both eyes.
Both eyes were out of control in the 30s and the 40s.
So can you address to us which eye is the most important in order to start our discussion? Which eye do you want to address first?
Well, obviously, the eye with the Ahmed valve, you know, leaves less room for intervention.
Yes, can you explain to us how is his conjunctiva in the quadrants other than the valve?
They were okay.
So he has good conjunctiva.
Yeah.
And the valve lowered the pressure by how much degree?
First, not, you know, first it went down as expected, but very soon the pressure climbed up again, and we could not take care of that.
But it reached with the valve first time to a target pressure that's accepted to you.
Oh, yes.
So I think you can start with doing some sort of transconjunctival surgery. If his open angle with gonioscopy, I can proceed with deep sclerectomy in the other quadrant. Or if the angle is closed and you did already get on this eye, you can proceed for another valve with less conjunctival dependence.
Yeah, you see, the thing is, his tissues react very violently, especially to the valve. So we were not encouraged to implant another valve because we said, well, what if we get the same reaction?
Perfect. So you did get for this eye?
Yes, and micropulse.
GAT and micropulse.
Yes.
There is a trend to use the thermal laser cyclophotocoagulation with a more guarded plan in the form of putting 4 seconds, 1.25 or 1.5 joule, 6 applications per quadrant for 3 quadrants without waiting for the pop. Yeah. This is a nice trend we are adopting nowadays, and it's something between the traditional thermal and the micropulse, and we are getting very nice results with it.
Good point. Good point. Thank you. Other suggestions?
I second what Dr. Abdelhamid just said. So we call this the slow coagulation technique, and this was described, although not published, by Doug Gasterland, and we have published our results on comparing the slow coagulation versus the POP techniques, and you know, they showed similar efficacy, although the safety profile was better with the slow coagulation technique. And we're actually also in the process of publishing our manuscript on using the slow coagulation technique of continuous wave laser on eyes with good vision as a primary glaucoma surgery.
Great.
Could you please get back to previous slides, summarizing the I'm so sorry. So we have a tube in the left eye,
yes,
and you gas and the micropulse in the right eye, right?
Yes.
And they both failed.
They both failed.
Okay. Maybe I would try. So you didn't do GATs in the left eye, right?
No.
No. Okay, maybe I can. Maybe I would try GAT in the left eye and just try to see what happens in left eye. Then maybe go for micropulse. So you did micropulse once, right?
Micropulse once, yes.
One. Maybe I can try a couple of times. I don't have micropulse. So I don't. So you guys have Ziad and you guys have much more experience than me. Maybe, but I can go for GAT again in the other eye first, and then maybe add some micropulse.
Just a question. One thing. The fact that the GAT did not work in the right eye, isn't it a predictive of failure if you do it in the left eye, especially after a tube? Like it didn't work in the right. Why would it work in the left after a tube?
Actually, yeah, you are right. This is a question in my mind. That's right. But I don't have scientific data proving that. But it's reasonable. Yes. We should work this. Actually, I don't have data showing the wound healing in the angle, so we don't have any idea. But yes, that's right. It's a question right now. It should be investigated definitely. But since it has a non-invasive nature, you know, I can ask why don't we try again and see what happens, and then go for other techniques. But you're right.
Okay. I think I'm going to proceed if nobody else has comments. Your comments are very valuable, and you will see that we did what you suggested in one eye at least. I decided to go for a more classical approach for the right eye that does not have the valve. I proceeded with a fornix-based trabeculectomy, although I'm fond more of a limbus-based, like Moustafa, and I used a heavy dose of mitomycin followed by several 5-FU injections over 2 weeks. And the reason for this approach is because of our experience with the other eye having reacted so violently to the presence of an Ahmed valve. So we anticipated another violent reaction, and we treated him intensively with mitomycin and 5-FU. And the reason I'm specifying fornix-based because I figured it involves less dissection and less stimulation of the tissues and less fibrosis. And sure enough, as of day one, he had a deep chamber with a good blood and a pressure in the high teens, low 20s that responded readily to focal massage. And with repeated massage and repeated 5-FU injections, he maintained a good pressure in the low teens. And as some of the colleagues suggested, we did a slow burn of using the diode laser on the left eye that had the Ahmed valve. And the post-operative follow-up, the pressure was always 8 to 10 millimeters in both eyes on no treatment. The right eye had a diffuse, thick bleb becoming gradually avascular as it received treatment. And he was followed up until mid-June, a few days ago, when he had to go back to Africa. And actually, only yesterday, he sent me a message saying that his pressure using the air puff tonometry in the Ivory Coast was 13 and 14 meters in the right and left eyes. So in the interest of saving time, and maybe we can do some further discussion at the end, let me just summarize the messages that can be learned from this case, that trabeculectomy is still an option, and the short-term morbidity can be minimized with meticulous technique and vigilant follow-up. Now, the reason we did not think of trabeculectomy as one of the options initially is because this patient was always eager to go back, and he said, I'm traveling next week, you know, the airport is closed, and they kept promising that it will be open and so on. So That's why we elected to choose procedures that did not require a lot of follow-up like trabeculectomy, which has the longest track record and can be working for years and years. And we're always afraid of long-term complications, but to my mind, these can always be managed. And I must admit that we always have trabeculectomy in the back of our minds when we keep wanting to spare the superior conjunctiva for future surgery by doing clear cornea phacos, by going to MIGS instead of conjunctiva involving procedures. So I'm not trying to defend TRAB as an exclusive choice, but always keep it in mind, at least until we identify safer and equally effective procedures. I just wanted to throw in this case to stress that we often forget classical approaches in favor of more modern procedures. Both are justified, but we have to individualize our cases. Thank you. Maybe we ought to leave additional discussion at the end and give a chance for the other colleagues.
Thank you, Dr. Thank you, Karim. Thank you very much for this wonderful and classic teaching. That's what I do myself. I learned that from you. Thank you very much. I'll go ahead now and share my screen. I hope I can. Let me see. Okay, and oh dear. Sorry about that. Here we go. Right. And we'll go from there. Right. This should be very short. Can you guys hear me?
Yes, Dr. Moustafa.
Good. Thank you very much. What is the approach to the patient with advanced or end-stage glaucoma? I have a lot of those here.
We can't see your screen, Dr. Moustafa. I think you shared the wrong screen. So if you go back to your screen and choose the window that that has your presentation.
Oh, I see. Stop sharing and share, and window is my presentation. Can you see that now?
Yes.
Yes.
Good. Thank you. Right. I have a lot of patients. I was faced with a horrible number of patients here in Sudan, and people coming from other parts of the Arab world with very advanced glaucoma, end-stage glaucoma. And I'm going to share with you some very simple tips that I use when seeing those patients. Advanced glaucoma, by definition, chronic or angle closure or open angle glaucoma, advanced visual field loss, inadequate intraocular pressure control, on maximum treatment, even with previous surgery. Risk factors include age, ocular pathology, and systemic diseases. All of these things can actually make your life harder. You've had a marvelous trap, and then the patient developed bad cataract, waited until the cataract was solid rock, and then came to you. Retinal vasculopathies are very common in this part of the world. And the most important risk factor for me here is family support, because that will indicate to you how much care this patient will have after surgery. I depend on assessment of the patient. I depend on visual acuity, visual fields, optic nerve, and then there is the functional reserve of the eye and the health or vision-related quality of life. There is no point of operating on somebody who's hand motion, for instance, and hoping that for that vision, I'm sorry, for PL, and hoping for that patient to improve. But if there is enough functional eye, and he can depend on that to carry on a healthy life, sort of, then yes, I would go ahead with that. So for that, we need to test the visual fields, if possible, the visual perception, and sometimes, because some of those patients have developed cortical pathology that will not enable them to actually perceive well. his visual needs. Some people are professors in universities, some people are farmers, and that has to be put into consideration. And of course, his personal ability and attitude. We have functional vision. People rarely come to me in that stage. Useful vision, maybe, and ambulatory vision, that's what most people come in with, maybe visual independence, or and we need to provide visual independence and avoid self-negligence. How to maintain it without adding morbidity? Maybe sometimes you don't have to interfere because you'll add a lot of morbidity without any use. How can we help improving his health-related quality of life is one most important question. Now, visual fields are not very reliable, and we have to decide every time, is the pattern corresponding to pathology or not? Because as you know, glaucoma can be mixed with cerebral cortex infarction, and we wouldn't know. One of the little tricks that I use all the time is to change the spot size in advanced patient. This patient had such a field, and she was really depressed, being tested by size 3 every time. And then when I changed that to size 5, life became a lot better, and she was more compliant with her medications, and her whole life improved just because of we changed the spot size to 5, which of course covers a lot more, 3 times more than the 3 receptive fields, and that helped her quite a lot. Also, I use when I decide on surgery for advanced cases, I depend mainly on the central 10-2 visual field, because as you can see, this is the amount of spots, about 16 spots being tested when you use the 30-2 visual field. However, if you use the central 10-2, there's a lot more visual appreciation in that area, and this central area, this central small, about maybe 1 or less than 2 millimeters in the eye, is represented in the brain and in the visual cortex by about 60% or more than 60%. So that's a very important area for the patient. And here is a patient with central fixation. I mean, the loss has approached central fixation, but when we used the central 10-2, it became quite a different story. For the first one, I wouldn't touch this patient, but here, for fear of wipe out. But here, this is the real thing. This is a central 10, and as you can see, it's not really cross-fixating, and I can go ahead at ease. Despite normal intraocular pressure, people lose their sight to glaucoma. You need to think of vascular risk factors, importantly, diabetes, new ocular pathology, the patient has developed retinal vascular occlusions, and you need to redefine your target intraocular pressure, of course, all the time. Again, I have a lot of patients referred on medical glaucoma, and for years, and they were told that you have a very bad disease, and they all turned out to be congenital anomalies and stuff like that. So you have to make sure still in a very advanced patient, referred to as advanced glaucoma, is it still glaucoma or not? Now, this patient developed retinal vasculitis secondary to sarcoidosis, and of course, his life and the fluorescein angiography, you can see the communications between the superior and inferior parts of the temporal retina, indicating chronic ischemia. And then all of a sudden, he developed vasculitis as well, which added to his misery, really. But that's drop of vision, not related really to the glaucoma itself. Here's a patient, male, 55, diagnosed with glaucoma for 1 year. Family history very strong for glaucoma. The intraocular pressure at diagnosis 14 and 18, right and left. And then when he came to me, it was 12 and 14, ambitoptic and travertan. His visual acuity was 6.6 in the right eye, and counted fingers at 2 meters in the right and the left eye. And this is the visual field. I mean, you cannot have such a central loss stage in glaucoma. It's unless the patient is blinded by glaucoma. But to have visual field effect, that was in May, and in December of the same year, he's improved. So his performance has improved, but this was a classic traumatic optic neuropathy rather than glaucoma, and it looked just like glaucoma. So when do we operate? We operate when there is progressive visual function loss despite maximum tolerable treatment, controlled systemic disease. You have to control systemic disease. Sometimes I start people at insulin, diabetics, not really controlled, but okay-ish. I start them on insulin in order to enter an eye which presents to me with a pressure of like 6 something. and there is enough functional reserve to maintain a health-related quality of life in the eye. The most important item here is repeated discussion with the patient and the family regarding the risk and morbidity of the surgery, because if you don't do that, people think that once you do the, I mean, some people ask me, are you going to do it with laser? That tells you how much ignorance is about in the society about doing glaucoma surgery. So you have to have this detailed, repeated discussion with the patient and the family, because the family are going to take care of him after the surgery regarding the risk and the morbidity. This is, I'm going to just mute this. This is the lady. One of my routine tests is to ask them to cover the blind eye by that time and ask her to use her only eye to go towards the door and see if she can at least ambulate freely in the room. That means that she can take care of herself. Nobody's guiding her. She just came back to the, notice her head. I mean, she's making sure of every step. That's because of the very, very small remaining visual field. But this lady had surgery and she went okay. I think we need to stop this. No. Now, visual acuity of head motion or counted fingers at close distance, I wouldn't touch it. High intraocular pressure, yes, that's not a problem. No renal impairment, then I would go for an aggressive lowering of the intraocular pressure. And how do I do that? I give him acetazolamide, Diamox, 250 milligram tablet QID for 3 or 4 days, and then ask them to go home, rest, and then come back to me in 3 days. And I test the pressure again. If they have a good response, then I would go ahead with that, with surgery. If there is visual improvement, if there is lowering of the intraocular pressure, because sometimes you do that and the pressure never goes down. And the vision really is the same, head motion as it was, or counted fingers at close distance. Now, regarding the anesthesia, I have a very low tolerance approach with advanced disease. So if general anesthesia, no hypotensive tricks at all, you don't need, I mean, some anesthetists would love to actually make the patient hypertensive, but we should avoid that by all means, because that's very harmful to the cerebral circulation, something that you count on. If local anesthesia, please, no retrobulbar injections at all, of any sort, because in all kinds of glaucoma and all kinds of patients with glaucoma, especially advanced glaucoma, the retrobulbar circulation is really badly affected and compromised, and I wouldn't add any volume to that small volume behind the eye. My approach is slow lowering of the intraocular pressure using mannitol 200 milligrams over 20 minutes or so, using very slow paracentesis, that I'm going to show you that, and using some tricks with the scleral flap dissection. By all means, avoid hypotony. Avoid hypotony, avoid hypotony. At the start of the surgery, at the middle of the surgery, at the end of the surgery, avoid hypotony. And always watch for horrible things that might occur, like malignant glaucoma or choroidal hemorrhage, God forbid. So this is the video of the paracentesis. I know you guys don't need that, but maybe some of our colleagues are not glaucoma surgeons. I go very slow, and slow motion, slow motion, slow motion, and then I get really slow and then get inside the eye and open and get out with a very small drop of fluid coming out. I test the pressure. If I'm happy that this is okay, if not, I can test this opening. This is a small spatula and it doesn't go through, which means that the opening is really very small and self-sealing. Self-sealing is a point, because this is my target, because otherwise I don't want any leaks. In this case, we went too low, and so I increase it a little bit, and that's the pressure that I can work on. At the end of the surgery, I use the same opening to reform the anterior chamber and the bleb, and watch carefully for a few minutes, making sure that the anterior chamber depth is maintained and the bleb height is maintained. And that would be, for me, the end point of the surgery. Right. So again, here is another trick. I do dissection like scleral flap, like everybody. And then it's a very old thing that I was taught back in the 80s. Put a stay suture, a guarding suture. It's there. Once I finish my business inside the eye, very quickly I put some air here to watch for choroidals, and then I closed it, tin or nylon. That makes my life very easy when I try to insert removable sutures. It makes it very easy and very precise at the same time. And here we go. And you can just get rid of this if you wish, or keep it. And that's that. Is surgery enough? Sometimes not. It depends on the final postoperative intraocular pressure and the visual function, of course, and how much did we retain. It's either stabilized with a slower rate of disease progression, or of course worsening or improvement, which doesn't happen really, except very rare. Now, in conclusion, you need to confirm diagnosis. Funnily enough, in some of those cases coming with advanced glaucoma, you still have to confirm the diagnosis because it might not be glaucoma at all. You have to check for the impact of associated pathology on the eye and systemic pathology. Quality of residual functional vision. You cannot go fly an airplane after having your vision drop as such, and you have to maintain a sedation life and so on. You advise the patient and the family. Planning for intervention, increase morbidity, improved health and quality of life, and share knowledge with the family as much as you can. Thank you very much. That's it.
Thanks so much, Dr. Moustafa. Okay, any comments from our panelists on Dr. Moustafa's approach?
اوكي دكتور محمد، حضرتك هتعمل شير سكرين؟
Karim is muted, Zainab is muted, Ziad is muted.
Hi.
Hi.
Moustafa, two things. I like to do my paracentesis inferiorly so that it is handy if I need to manipulate the chamber post-op. That's number one. Number two, if you're keen on avoiding hypotony, and of course you should be, how about using viscoelastic at some stage?
That one was thank you very much, Karim. That one was actually inferior at 6 o'clock. It's just the way the video was put, but it's always inferior at 6 o'clock because I deal with it at the slit lamp. The other thing about viscoelastic, of course, sometimes I do that, but not all the times, especially when it involves something like a combined phacotraph. The last case I showed was a combined phacotraph, and I would like to always observe that air bubble in the anterior chamber, because if it gets flatter, then that means something is coming, pushing it from behind, and I should stop. I always anticipate and watch for malignant glaucoma as well as choroidals during glaucoma surgeries, especially with the kind of patients that I get.
And pre-placing the sutures is quite vital, because you can close immediately rather than struggle with the eye while it's open.
Absolutely true. Yes. I spend as much short as time I can and possible in the anterior chamber, and then I close it immediately.
So we have a question on the chat asking, in advanced glaucoma surgery, why don't you go to deep sclerectomy as a safer alternative to trabeculectomy? This is one of the questions that came up in the chat.
Well, for two reasons. Thank you very much, Ziad. For two reasons. One is I'm quite used to trabeculectomy, of course. The other thing is it's been proved beyond anything that the complication rates and the complications themselves from deep sclerectomy and trabeculectomy are almost the same. So I prefer a trabeculectomy unless I would go for a deep sclerectomy, for instance, combined with trabeculotomy in congenital glaucoma, but not in my patients with severe glaucoma first.
Zainab,
yeah.
Would you prefer? It's exactly the same kind of question. Would you prefer some minimally invasive glaucoma procedures like suprachoroidals or GAT just to avoid the risk of complications to, for safety. Because in those kind of patients, we have, yes, risk of vision loss, and we need low target pressures, so that's it. But in other way, we have a high risk of surgical complications, We need to decide, we need to escalate some kind of, So what do you think about mix in those kind of patients?
Thank you very much for this, Dr. Zainab. I did when I target for a pressure of 10 to 8, then I wouldn't go for MIGS. Having said that, I have to tell you that I've started doing GAT about a couple of years ago, and in one of my cases, actually, I did 2 traps, and then instead of doing an Ahmed valve, I did a GAT inferiorly, and it worked marvelously. But that was one patient, so my GAT number is not that big. However, that worked for me. But most of the time, I'm targeting a pressure of 8. I go for trap, the way I discussed it.
That's a great point. Actually, it was my point. So we mostly have an advanced cases, and I have a GAT experience mostly in advanced cases. And actually, we published it. We have a data, and it works very well in advanced cases, especially in cases with pseudo-exfoliation. So it makes sense, the primary pathology is in the trabecular meshwork, and you incise it in the half of the way or circumferentially. So it works very well, even in hemigap cases. So I changed my approach in those cases. So I start with GAT first. You don't even need to do a 360 trabeculotomy, hemigap is working very well in those cases. So for safety, my approach is like that. I start with GAT in those cases. So if it's not necessary, if you don't reach the target levels, you can go ahead and add some medications instead of taking risks. It's good to know. Yeah.
Thank you very much. Actually, the kind of patients I have here are marvelously advanced, all of them. And those who are not advanced have nothing, have no glaucoma. I have 2 types of glaucoma patients. Those who don't have glaucoma at all, being treated for 10 years, and those with very bad disease coming to me with 1 single eye functioning. And if I've been doing a trap for more than 30 years, maybe 36 years or something, and I'm very comfortable with it. However, I have to tell you that in that case, which worked with me after 2 traps, it was a hemigat because I had a nice, clean, inferior half
angle
of angle, and that was great. But that was one case. I don't have much experience in doing a lot of GAT on advanced glaucomas because I really can't dare to do that in an eye that I know I can serve better with the technique that I'm very comfortable with.
Yeah, you can get low teen pressures or sometimes single digits in pseudo exfoliation. It works very well. Thank you. Great points.
Thank you. Thank you very much. Ziad, hello.
Yeah.
Dr. Ziad, would you like to go ahead? Ziad is going to tell us a story about a box of chocolates, I believe. So why don't you carry on and tell us the box of chocolate story? Here you go, box of chocolates.
So you can see my slide?
Yes. Thank you.
Okay, thank you, Moustafa, for organizing this. So the title of my case today is going to be a box of chocolates. So this is the case of a 50-year-old male who was followed up at the retina clinic since 2012, basically. He was diagnosed with CNV, choroidal neovascular membrane, for which he received more than 20 injection over the course of 3 years. So from 2012 to 2015, he almost had 25 anti-VEGF injections, and the IOP was well controlled so far. And in 2016, they decided to switch him from anti-VEGF injection to dexamethasone intravitreal implant injection. And in June 2016, so 6 months after his first dexamethasone injection, he started to develop an increase in intraocular pressure, and they put him on glaucoma meds. After that, he underwent an uneventful phaco with IOL implantation, and he was well controlled on maximum tolerated medical therapy with an IOP that was in the mid to low teens over between 2016 and 2019. So 3 years on dexamethasone injection with a well-controlled pressure with maximum tolerated medical therapy. So when you see that the pressure starts, to increase in those cases, I think someone needs to mute their microphone. I hear someone speaking on the phone. So what I was saying is, you know, in some cases, when you see those patients and you see that the pressure is started to increase and they start to need glaucoma meds when they are taking those dexamethasone injection, you know that you're in front of a ticking bomb. And this was exactly the case for that patient when they referred him to me after 2 years of dexamethasone injection. The pressure was 42 millimeters of mercury in the injected eye on MTMT, maximum tolerated medical therapy, including oral acetazolamide. So, you know, in those cases, when there is something that goes beyond a certain pattern, usually when you feel that there is something fishy or when you have a doubt that something is going on in glaucoma, usually it's true. So you need to follow your hitch. And this is basically one of my favorite movies with Tom Hanks, who's an amazing actor. And this quote that is really amazing is that his mama used to tell him, Forrest Gump, that life was like a box of chocolates. You never know what you're gonna get. So whenever I'm facing a patient like that, when my instinct tells me, you know, that there is something happening, you know, this guy has been having his injections for 3 years without any major problems, and now you have this acute rise of intraocular pressure that is refractive to all glaucoma medication. There's probably something new happening here. So I put my gonio lens, as I do for every single patient that is referred to me, and I find this little bad boy sitting in the inferior angle. So basically what you're seeing here is the dexamethasone implant that migrated into the anterior chamber, and it's sitting here, as you can see, just facing the inferior trabeculum in the inferior quadrant. And probably, you know, the fact that this implant migrated in the interior chamber was causing this acute and violent rise in intraocular pressure. So the patient did not want to have any type of surgery. He didn't want to have the implant removed. He didn't want to have any glaucoma drainage device filtering surgery. He just wanted to wait for the implant to dissolve. We tried to consent him many times for surgery. It was basically impossible. So he basically agreed with the retina surgeon to come every other day to the glaucoma clinic, to the retina clinic, and he was having a paracentesis basically every other day over the next 2 to 3 weeks. And you can see that the pressure was at all visits somewhere between 30 and 40. And then at a certain point, the dexamethasone implant was not visible anymore on gonioscopy, and we had to have, you know, this discussion, sit with our patient and tell him, you know what, the implant's not there anymore, the pressure is not likely to decrease. But it was extremely difficult to convince him to have glaucoma surgery. So what would be next, you know, in a patient like that, who's very difficult to consent for surgery, who's not satisfied with the safety profile of drainage devices or trabeculectomy? What would you what would be your go-to option to discuss with such a risk-averse patient? Any comment, Moustafa? We can't hear you.
Okay, sorry. Can you hear me now? Sorry.
Yeah, we can.
That's a very tough one. He's refusing surgery, basically, right?
Any type of we discussed trabeculectomy, we discussed drainage devices. He was not very happy with the safety profile.
How about cyclodiode?
That would be an option, but I'm not a huge fan of diode in eyes that received multiple injections. You never know how they're gonna react.
Yeah, I would. Well, if he's controlled medically, then I would try to convince him to go for surgery. Really, either deep sclerectomy or trabeculectomy or a valve, because that patient will continue coming back to you if you didn't do that.
Yeah, so the pressure was 42 on maximum tolerated medical therapy, including oral acetazolamide. Abdelhamid, were you trying to comment?
Yes, I'm just want to try at first to calibrate the risk for this patient, whether stopping his steroids by any mean will keep him in a glaucoma state or will get him back to a normal intraocular pressure. So I want to ask about the other eye and his refraction and family history, things that will put him in high risk for steroid-induced glaucoma that will maintain forever. This is number one. Number two, I have performed a lot of deep sclerectomies in steroid-induced glaucoma, and I published a paper. I will send it to you. It's very safe because it's a type of secondary open-angle glaucoma that does not put the patient in a state of hypotony. And it's marvelous. You are promising him a safe procedure. So I would suggest at first to calibrate the risk for him to be steroid induced after the implant has gone away. Number two, I suggest a non-penetrating surgery, especially that is open angle. And I want to tell you also that this was my adopted technique before going into the new angle surgery, like the elegant GAT that I can consider nowadays.
Good point. What about you, Mohamed? What would you do as a next step for this patient? What would you discuss with him?
So I know that GAT is a very attractive option. However, I know there is a recent publication by my friend and mentor, Peter Chang, about GAT and whether it's actually better to use post-operative steroids versus non-steroidal anti-inflammatory medications. And I was aware of the results well before they were published. So the results were that actually patients who get non-steroidals after GAT do better than patients who actually get steroids after GAT. And, we don't really know the mechanism, but maybe like steroids actually, kind of like, clog the collector channels or something like, beyond the trabecular meshwork. So I'm not sure that GAT would actually be the best option in a patient with a non-steroid-induced component. But I would certainly try GAT before anything else, though, having said that.
Great point, Mohamed. I don't know if Zainab's still on the panel. Does Zainab have any comment concerning steroid response after GAT?
It's a great case, thank you. For this case, I would definitely try to convince this patient for surgery, and I would go, deep sclerotomy might be an option, and GAT might be definitely be option. I have a subgroup of patients with steroid glaucoma, so it works very well also in those cases. KDB might be another option. I would do GAT, and then in the early post-op period, as I do in every patient, I would switch from steroids to topical steroids to non-steroids as soon as possible to avoid IOP peaks, because these peaks is very common in every patient, not in those cases. You know, it's very common, like 20% or 21% of something like that in our patient series. So that's what I would do.
Great point, Zainab. Thank you. So, as you already suggested, we decided to go for a GAT. The patient was convinced with that option. He didn't want to live for the rest of his life with a tube in his eye, and he was basically also afraid of bleb-related complication with trabeculectomy. So GAT was, when we discussed the option, GAT was the most appealing option for him. You know, the fact that it was minimally invasive with a satisfying safety profile. So we decided to go for a GAT. The evidence that we found in the literature back then was not that significant. There were 2 case reports, one adult patient following PKP who had steroid response, IOP of 48, went down to 13 after GAT. Another pediatric case report, pressure of 38, went down to 12 after GAT, also steroid response, and a retrospective study coming out of the US on 13 cases with steroid-induced glaucoma undergoing GAT. You can see that there was a major decrease in intraocular pressure in this study. Baseline IOP was around 26, went down to around 10. So it's a good pressure reduction with a significant reduction in the number of glaucoma meds. And what's interesting in this retrospective study on steroid-induced glaucoma is that all those patients undergoing GAT had the pressure less than 15 at their last follow-up. So we felt quite positive about the outcomes of this type of procedure. I'm going to show you the surgery in this patient. So for those who are not familiar with the technique, what I'm doing here is that I'm opening a slit using an MVR. I'm incising the trabecular meshwork, and I'm pushing the lip of trabecular meshwork. I'm pushing it down, exposing the back wall of Schlemm's canal. And what you see here is the proline with a bulb on the tip. I basically cauterize the 5-O-proline to obtain this small bulb. And using MST microforceps, I slide the proline suture in Schlemm's canal. And what you do here on the direct gonioscopic view is that you're going to do 30 to 40 1-millimeter passes using your micrograsper, and your proline suture is going to travel circumferentially 360 in Schlemm's canal. And at a certain point, you're going to see the tip of your proline suture getting there, and you push a bit more to reach that slit, that opening that you created at the beginning of the surgery. And what I'm doing here is wrong. I should never reach underneath the proline to grab the bulb. I should reach above the proline, because otherwise I would be risking to catch the iris with the microforceps. And then I use a tying forceps to pull on both ends of the suture to do my 360 trabeculotomy, and this is what GAT is. And you have this beautiful reflux of blood from Schlemm's canal, from the collector's channel. That is a good prognostic factor. And I'm burping out my helon, and I have this beautiful episcleral wave that indicates that there is some patency in the outflow system. and this is also a good prognostic factor. In 1/3 of the cases after GAT, you're going to end up having a high FEMA according to studies, and this is our patient on post-op day 1. You can see his high FEMA. I usually leave 1/3 of a fill of AC with viscoelastic and an air bubble to tamponade the bleeding and sort of pushing it down in a way from the visual axis. And after GAT, over the next 2 months, more or less, I had the pressure in the low teens. The pressure was really well controlled. But then you see here on the last 2 visits, I had a drop of pressure. It was around 5 millimeters of mercury. The patient was not very happy with his vision here. So I knew that something fishy was happening. Usually I get pressures around 10 or low teens with GAT, but this was, way too good to be true. It was way too low, basically. And I was telling you, in glaucoma, whenever you suspect that something fishy is happening, it's usually a box of chocolate, and there's usually a surprise in that box of chocolate. I couldn't see the fundus of the patient because he was on pylo. I usually put some of my patient on post-op pilocarpine. So I ordered a B scan, and unfortunately the patient had a retinal detachment, as you can see here. So I refer him back to the retina clinic. He underwent a pars plana vitrectomy, stripping of epiretinal membrane with gas injection and anti-VEGF, and the postoperative course was uneventful. So just to remind you where we started with, the patient had an IOP of 42 millimeters of mercury on MTMT, including oral acetazolamide. And here we are 1 year after the surgery. The pressure dropped from 42 to 9 millimeters of mercury, so around 80% IOP reduction, with a significant decrease in the number of glaucoma med, including discontinuation of oral acetazolamide, and the patient is quite happy with the results. So that was my case for today. So basically, when you're stuck in some unfamiliar scenarios, you should always look further for something happening that is causing this unfamiliar or surprising reaction, and also you should try to think outside of the box. Not always go to the traditional filtering procedure or drainage devices, and think of other new innovative alternatives like GAT in those scenarios. Thank you.
Thank you very much, Dr. Ziad. May I ask you a question, please? What was the reason for the retinal detachment, do you think? I mean, you showed us the surgery. It was marvelous.
Well, very good question. I discussed this at length with Zainab back then. The retinal detachment happened 2 years after the GAT procedure. The GAT procedure itself was uneventful. I think it was probably just bad luck. He had a retinal detachment that was unrelated to the surgery, given the fact that it was 2 months later. It could also be due to pilocarpine, but I think that retinal detachment caused by pilocarpine are a big myth. I don't think that pilocarpine has a role to do with that. So I just think that it was just pure bad luck, unrelated to the GAT surgery. It was just a pseudophakic retinal detachment.
Don't forget he had multiple injections before.
Multiple injections also could be causing vitreous movements or something like that. But it has never been described, retinal detachment as a complication to GAT. I know that Zainab wrote a paper on choroidal effusions after anterior choroidal effusion after GAT, but this was a rhegmatogenous retinal detachment, and we saw actually a retinal tear during the vitrectomy.
Yeah, I can say a couple of things. I totally agree. You were just unlucky, I guess. It happened 2 years after the GAT. So So apparently this has nothing to do with GAT surgery. So her surgery is uneventful, so it was very smooth. So one of the risk factors is definitely, as mentioned, the multiple intravitreal injections. I agree. And when it comes to GAT, and as a complications, we have a couple of patients, as you said, with supraciliary effusions, and we published that, and they were totally normal patients, no any other predispositions like uveitis or any, and the surgeries are uncomplicated surgeries. So this might happen in also in patients underwent ab externa trabeculotomy. So you can see some suprachoroidal fluid anteriorly, and they resolve spontaneously. But retinal detachment is not. I mean, it's hard to see in those cases. But one of the important thing is we need to keep on mind is in patients with incisional with a history of incisional surgery with PIs. Sometimes it might during threading you need to observe the tip of the suture if you are using. So it's kind of blind procedure. It might get into the posterior segment sometimes. It happened to me, and then I stop and draw the suture. You know, it might sometimes get into the PI and go to the back of the eyes. So in this clinical scenario, it might hit to the retina. So it's possible, but in this case, it has, I think, nothing to do with GAT surgery. This is a great case. Thank you.
Well, there are a couple of comments on the chat, you know, saying that, you know, pilocarpine could be the cause of the retinal detachment. You know, this is the classical teaching, you know, in every textbook or every residence course, you know, they tell you that one of the complications of pilocarpine could be retinal detachment. But we reviewed extensively the literature when we discussed that case with our retina specialists, and we presented them during that case during many of our institution meeting. The evidence incriminating pilocarpine in the development of retinal detachment is only anecdotal. And if you go back to the literature, and I don't mean of, you know, textbooks that talk about that, but if you go back to the evidence is very poor. And most of the retina specialists would tell you that, you know, this is not backed by real evidence, and the reports are, you know, at most anecdotal. I don't know what Mohamed, what do you think is there a relationship between myotics and retinal detachment? Is it something that is scientifically agreed on?
I actually have never seen a case. This is something that, like, you know, I've heard during residency in my residency years. But it's really hard to believe that without a strong predisposing factor, like, you know, a tear or something, that like these by themselves would cause a retinal detachment out of the blue. It just doesn't make sense. And I agree that the evidence is at best anecdotal. I have asked several people, and they have not seen a single case.
Totally agree with you, and we inject, you know, myocol in cataract surgery routine.
Myocol in every case of GAT on a phakic patient, and then in every combined cataract glaucoma procedure, no matter what the glaucoma procedure is, whether it's a MIGS or a tube. So after I'm done with my cataract portion, I inject Myostat or myocol, and you know, of course, like, you know, in all phakic GATs, I also inject Myostat or myocol.
By the way, we, the old timers, and Moustafa can vouch for that, we lived with pilocarpine. At the time, we had pilocarpine, epinephrine, and Diamox. That was about it. And by the way, you know, pilocarpine is still one of the most effective drops for glaucoma for people who can tolerate it, and it's cheap.
And actually, Dr. Karim, so there are people who still use pilocarpine who are in practice, and I know them in teaching institutions here in the U.S. who prescribe pilocarpine regularly, and others who prescribe phospholine iodide even. And what also, I have a particular use for pilocarpine in IOP spikes after GAT. And this is not evidence-based, have seen it done, but this is something that works in my hands. When I have an IOP spike after GAT, I put the patient on pilocarpine 2% QID, and the vast majority, I don't have numbers, but the vast majority actually go through the hypertensive phase and regain a bit pressure.
Then
great point.
You have the elderly pseudophakic patients love it because it gives you the pinhole effect, and so many of them see better actually.
So thank you, Mohamed and Karim, for the great comments. So someone was asking on the chat, why did the patient take pilocarpine drops after GAT? I think Mohamed answered that. Sometimes when the patient spikes after GAT, we use pilocarpine as a first line, and you get really good IOP lowering effect with pilocarpine after GAT or even after KDB. Another comment, in PDS, pigment dispersion syndrome, pilocarpine might have a higher risk for retinal detachment. I'm not aware of the evidence concerning risk of retinal detachment following with pilocarpine and pigment dispersion syndrome. I think that pilocarpine might prevent IOP spikes in pigment dispersion patient by pulling the iris away from the zonules. Sometimes you can give that to your patient before the workout or something like that. This is not evidence-based, but this is something that most of us have been taught during our glaucoma training. Anyone familiar with the specificities of pilocarpine in pigment dispersion patients? Abdelhamid, Mohamed, any comments on that?
Actually, I have 2 patients with pigment dispersion, and I adore lens removal as early as possible as the sole and the most important source of friction between the iris and while during meiosis and mydriasis, and I have OCT for such patients, and I found by anterior segment OCT that there is a touch between the lens and the back of the iris, which was totally absent after replacing the crystalline lens, even in clear lenses with IOLs. This is the main way for managing such patients as a starting step. But I'm not used to pilocarpine because we don't have a lot of available pilocarpine in Egypt nowadays.
I would not advocate for lens extraction as a first line for pigment dispersion when it comes to my practice. What about you, Mohamed? Any input on pilocarpine and pigment dispersion? Any comments?
I really am not sure. So we know that in pigment dispersion, we have this posterior bowing of the iris, and pilocarpine and all myotics would push the lens iris diaphragm forward. I just don't know the mechanics of it, how it would affect the contact or friction between the iris, the back surface of the iris, and the zonules. I'm not, quite sure, to be honest.
What about the comment of Abdelhamid, lens extraction? Would it be an option that you would consider?
Makes a lot of sense. Makes a lot of sense. We just need to remember here that pigment dispersion treats itself in a lot of patients. So particularly in, here in the US and patients with blue and green irides. And because the amount of the iris pigment epithelium is definitely less than in brown irides. But there is only so much pigment that can get released. And actually, there is a the natural history of the condition is that it actually improves on its own after some time, because all the pigment will have been rubbed off of the areas of the iris that are in touch or in contact with the zonules. But it makes a lot of sense. I don't have this is not something that comes to my mind the first thing when I see a patient with pigment exposure, to be honest, but it makes a lot of sense to me.
The very bad thing about pilocarpine is actually its effect on the ocular surface. It has a horrible effect on the ocular surface with time, and that's unfortunate because it's a good drug. Karim said we belong to the area where pilocarpine and that was it. So it is horrible to the ocular surface. I can attest to that. So, Dr. Abdelhamid, would you like to go ahead, please, with your presentation? Dr. Abdelhamid is going to talk to us about some of his interesting cases in malignant glaucoma.
Actually, our talk today about nanophthalmos and glaucoma, and we are showing in this slide different age groups because our disease presentation and management differ among different age groups. This is the clinical spectrum of the small eye phenotypes. We are talking mainly about nanophthalmos, which is the last one in this table. However, some ophthalmologists by mistake exchange the nomenclature between nanophthalmos and posterior microphthalmos. However, the two terms represent two different conditions. Nanophthalmos show a short axial lens with small anterior and posterior segments, thickened choroid and sclera with normal lens volume. On the other hand, short axial lens, posterior microphthalmos show short axial lens with normal anterior chamber dimensions. Are these cases commonly seen? Actually, yes. They are represented genetically on 6 locations. 3 of them are autosomal dominant. So in autosomal dominant fashion, we might see a lot of the nanophthalmos running in families. So once you catch a case, if you are tracing his brothers or sisters, you will find similar conditions with variable degree of the pathology. These are some of the typical ultrasonographic and retinal features of nanophthalmos. Axial lens, short axial lens, thickened sclera and choroid, serous retinal detachment, choroidal effusion, shallow anterior chamber, angle closure, anterior rotation of the iris lens diaphragm. Also, the spectralis OCT showing prominent choroidal and retinal folds in this small eye. Also, foveoschisis and choroidal folds. This is colored picture showing the optic disc drusen, chorioretinal folds, and crowded discs with mild vascular tortuosity. This is also a picture for papillomacular folds. And it's nice to show that these folds do not involve the retinal pigment epithelium. So the term posterior microphthalmos is not synonymous with nanophthalmos. Although both conditions are characterized by shortened axial lengths and high hyperopia, yet in nanophthalmos, the anterior chamber dimensions are decreased. Corneal diameter is less than 11 millimeter, whereas in posterior microphthalmos, the anterior segment is of normal or slightly abnormal size. Thus, the phenotype of posterior microphthalmos does not include the predisposition to angle closure glaucoma, which is part of nanophthalmos phenotype up to 70% of cases. Additional findings of posterior microphthalmos include retinal folds in 24%, occasional pigmentary retinopathy, and propensity for uveal effusion, which are not common features to nanophthalmos. Published reports and my own experience suggest that the posterior microphthalmus is a distinct autosomal recessive isolated ocular phenotype. Normally, the lens to eye volume ratio is about 4%. However, in nanophthalmic eyes, this volume ratio is more than 10 up to 30%, and still this progressively increases with age. No role for medical therapy in nanophthalmic glaucoma before lens surgery. Pretrabecular angle closure, either early oppositional or late synechial, would encourage us to adopt angle surgeries after lens removal in order to regain drainage, goniosynechiolisis together with lens surgery. So what type of glaucoma are we facing? We are facing a condition of chronic narrow angle glaucoma. However, it's not classical because it's not episodic, it's creeping, does not need precipitating factors, yet still precipitating factors can induce extra damage, and it does not follow the classical age presentation and profile of progression. The presentation varies according to age. Young people usually want to get rid of their high plus lenses. However, corneal laser surgery does not offer satisfying results. Also, the customized IOLs are not usually available with high plus powers. So we are adopting a two-staged refractive intervention plan from the very beginning to give better results and avoid refractive surprises. This will encourage early intervention. The trend of not giving solid promises to be spectacle-free after surgery will abandon the idea of lens removal, so underestimating the actual long-term benefit of lens removal. We have two options for refractive error correction in such cases. The first option is the single-step 2 piggy bag IOLs, yet pigment dispersion, interlenticular opacification, and still progressive angle narrowing can still occur. Or the planned two-step surgery for more refined results. The second step deals with the residual refraction as an aphakic state, with putting the iris claw lens as a secondary IOL becoming suitable with more deepening of the central anterior chamber. And this is a clinical study in 2019 comparing the refractive outcome of primary piggyback intraocular lens versus secondary lens iris claw in posterior microphthalmus and nanophthalmic eyes. It was done to compare the refractive outcome of two different methods of intraocular lens implantation in cases of nanophthalmus and posterior microphthalmus with primary piggyback IOLs versus secondary iris claw lens. The study found that the primary piggyback IOLs showed less satisfactory results with cases of undercorrection and the possible complication of interlenticular opacification. Both groups showed good safety parameters. However, we are facing difficulties in diagnosis of glaucoma in nanophthalmic eyes because of the fallacious IOP measurement due to changed corneal biomechanics and curvature, which would affect the validity of applanation tonometry. Also, the central corneal thickness factor should be included as it will overestimate the values. Optic nerve head size in these eyes is small, so slight cupping, which is the only sign of glaucoma, might be missed easily. Visual field might be misleading due to high plus lenses used, amblyopia, and posterior pole folds that might be present in such cases. So its benefit is more after discarding the spectacles by good refractive outcome when it is used as a baseline for further follow-up. Spectral domain OCT is the most beneficial and reliable for establishing a baseline for follow-up. Also, gonioscopy is technically difficult due to steep and small corneas, but still can be replaced by anterior OCT and UBM. Glaucoma surgery is hazardous in nanophthalmic eyes because of poor drainage of the vortex vein due to thick sclera characterized by abnormal collagen fibrils, leading to high incidence of supraciliary and suprachoroidal effusion, which needs prophylactic inferior quadrant sclerotomies. Because of high incidence of malignant glaucoma, we should consider routine peripheral iridohyaloidectomy together with lens surgery, vitrectomy with violation of the anterior hyaloid face, and even routine post-operative atropinization. Also, the deeply set orbits and limited episcleral space will make space for glaucoma drainage devices not capacious for adult devices. So single plate Multino or even the pediatric size of Ahmed valve might be used to avoid optic nerve compression accidentally. Evidence-based medicine does not offer guidelines in such conditions. And posterior segment findings might delay and encourage surgeon-patient couple to proceed for lens surgery. The laser use in such conditions is very much limited. YAG iridotomy, peripheral laser iridoplasty comprise only limited and temporary value. Endocyclophotocoagulation together with lens surgery should be limited and using low powers. Diode laser cyclophotocoagulation is risky as it is not calibrated and can lead to phthisis bulbi. This is an example of our cases done in the study, and this was a secondary artisan, aphakic artisan implanted in a 18 years old male. As we can see, he has an IOL in his bag. This nanophthalmic eye had an axial lens of 16 millimeter, and he had post-IOL implantation +8 diopter glasses, which was corrected with the artisan implantation. As we can see, this is the pentacam of this patient, and his AC depth increased from 2.2 millimeter to 4.4 millimeter. This is the IOL master for such patient, and it's of no benefit for implanting the artisan. We are relying upon the aphakic state and calculating the needed. This is the first case for management of nanophthalmic glaucoma. This is a 41 years old female patient with nanophthalmus with chronically narrow angle glaucoma and microcornea, high hyperopia +17, congenital nystagmus, crowded optic discs, and presented with poorly controlled glaucoma despite having peripheral iridotomy and iridoplasty. Despite maximum medical treatment in the right eye, she underwent trabeculectomy with mitomycin. However, she developed malignant glaucoma, shallow anterior chamber, iridocorneal touch, 360-degree posterior synechia, and visual acuity dropped to perception of light. So, she was referred to the vitreoretinal service for management of her cataract and underwent right pars plana vitrectomy, lensectomy, goniosynechiolysis through a pars plana approach, posterior capsulectomy and anterior capsulotomy, and cryotherapy, and he needed tamponade with C3F8. This is the second case, a 34 years old female with an nanophthalmic eye +10 glasses, managed by total lensectomy and vitrectomy. Her intraocular pressure was 30 millimeter mercury with maximum topical therapy. This resulted in widening of the angle by OCT from 16 to 40 degrees and needed aphakic glasses +20. IOP controlled to 12 millimeter mercury using maximum topical therapy, and iris claw lens with maximum power reduced the spectacles later to +7 diopter both eyes. This is the third case, a 54 years old male nanophthalmic, as we are seeing very shallow anterior chamber, and the corneal rigidity is different from normal eyes. He has chronic narrow angle glaucoma due to nanophthalmus. His right eye was managed with phacoemulsification together with peripheral iridohyaloidectomy. His IOP improved from 36 millimeter mercury to 14 millimeter mercury with dual topical therapy. So we are abandoning the penetrating trabeculectomy from our practice now in dealing with any chronic narrow angle glaucoma in nanophthalmic and non-nanophthalmic eyes to avoid serious conditions that might occur as malignant glaucoma and suprachoroidal hemorrhage and effusion. And we are adopting the angle surgery to break any pretrabecular block together with lens removal. This is the angle surgery in chronic narrow angle glaucoma, either the classical rigid trabeculotomy under deep sclerectomy after phacoemulsification, or the Prolene 5.0 guided elegant GAT in pseudophakic patients with post-operative gentle follow-up with minimal post-operative steroids in a conjunctiva sparing technique. It's not time-consuming, done under Helon after meiosis with certain OR settings to visualize the nasal angle. And this is a Prolene 5.0 guided 320-degree trabeculotomy ab externo under deep sclerectomy with preservation of the trabeculodescent membrane together with phacoemulsification. This will allow us to identify clearly the termination of canal of Schlemm. So we are happy with identifying the termination of canal of Schlemm and then cannulating the ends of the canal of Schlemm with the Prolene and doing the 320-degree trabeculotomy in order to preserve the trabeculodescent membrane and maintain the surgery in a closed system, avoiding the penetrating condition. As we can see in this chronic narrow angle, we are not seeing any seepage combined with phacoemulsification. And this is the creating the bulb at the termination of the Prolene, implanting and cannulation of the Prolene. Then doing the trabeculotomy, but trying to preserve the window.
So you do angle surgery and phaco together in this case, right?
Yes, definitely.
Mm-hmm.
Thank you.
Dr. Moustafa, please unmute yourself.
Thank you very much, Dr. Abdelhamid, Professor Abdelhamid. We enjoyed that very much. Do you guys have any question for Dr. Abdelhamid Hofi?
Yeah, my question was like why would you go for a posterior lensectomy in certain cases and leave the patient aphakic as opposed to, you know, putting an intraocular lens and going for an interior based approach?
Actually, I learned the condition the hard way. I did the trabeculectomy in such cases, and unfortunately, I faced malignant glaucoma more than once. And when you are talking with your patient, you are detecting his priorities. The priority of the patient who is young and looking for a spectacle-free condition, not caring about his glaucoma, or if he's not yet in a glaucoma state, differs from a patient who is already been on therapy for months and years and complaining of the condition of elevated intraocular pressure. So I can adopt the technique of lensectomy and vitrectomy. This will put me in a very safe situation. Sometimes I do lensectomy with peripheral iridohyalodectomy as a routine, as I mentioned, in cases, in other cases, which still might be totally safe to prevent malignant glaucoma.
But wouldn't aphakia make your glaucoma risk higher and increase the risk of, you know, developing a worsening of angle closure afterwards?
Look, after lens surgery in such cases, I did a lot of cases, especially for refractive issue, looking for the angle and seeing the effect of lens removal on the angle totally will put the condition of the eye in a safe position as regards angle closure.
Actually, I have been doing in nanophthalmic eyes, like, you know, just anterior approach cataract surgery, and then I would put in a lens for sure, and then I redo zonulohyalidotomy with the vitrector. So I go with I put an AC maintainer, and then I go with the vitrector. I make a peripheral iridotomy, go through the zonules, and then into the vitreous cavity, and this just makes it a unicameral eye. And yeah, I've had good results in the few cases that I've done that way.
Yes, I have been adopting two techniques of iridohyalidectomy, Dr. Mohamed. Either I do it totally from anterior approach in a perpendicular fashion, either with surgical iridotomy followed by a perpendicular cutter through this iridectomy in order to complete the uni-chamber I am looking forward, or in a two-manner approach from anterior segment and pars plana approach in order to complete the task.
So what we're doing here is our first line is basically lens removal, but you know, a regular phaco anterior approach. We don't do the posterior lensectomy approach. So we do a regular phaco with IOL implantation. And sometimes we add to that scleral windows. So we do sclerectomies approximately 3 to 4 millimeters away from the limbus to decrease the risk of choroidal effusion and choroidal complication post-op. And if the pressure doesn't go down after phaco, then and I think Dr. Tomey can comment on that, one of our best option would be cyclophotocoagulation using the classical diode, because shrinking the ciliary body in our hands, you know, in those patients, improves the angle. It opens up the angle by rotating the ciliary body posteriorly, and it also decreases the aqueous humor production, and it works quite well in those eyes. And it's a non-incisional procedure, so you don't have all the risk related to incisional surgery. Any comment on that, Mohamed or Karim?
Yes, and the chamber actually becomes significantly deeper when you shrink the ciliary processes.
Yeah,
Mohamed, any comment?
Yeah, I have done also ECP, and you can see the shrinkage yourself, like, you know, before your eyes, and the you know, the iris moving backward. And yeah, I think it makes a lot of sense.
Yeah, the only thing is that, you know, I never combine lens extraction to cyclophotocoagulation in those cases, because you never know how they're gonna react, and you can end up having, you know, horrible complications like choroidals, hypotony, etc. So I usually use a stepwise approach, lens extraction first, and then the cyclophotocoagulation would be done as a second line if needed.
Can I make a comment? It's a great, excellent presentation. So thank you for your great points. So my approach in those cases is similar to Mohamed's. I start with lens extraction and then routinely add iridozonulohyalated vitrectomy, and in almost every patient to prevent malignant glaucoma, and sometimes I add the gonioscinical lysis in almost most of the cases. So the question is, so you showed some cases, and you performed angle surgery together with cataract surgery combo procedure. So in which patients you combine? In which patients you combine the angle surgery and the cataract or iridozonulohyalated vitrectomy?
Look, if I have intraocular pressure more than 30 and the anterior OCT shows extensive peripheral antisynechia and peripheral iridocorneal touch, I would go for lens surgery routinely with iridohyalidectomy. This is my routine in such cases. However, I will go for angle surgery as a second step if I didn't reach my target pressure with satisfactory treatment.
I mean, in which patients you do both in same session? I mean, so you never know.
In nanophthalmic patients, I didn't go for both patients in the same session, actually.
Okay.
But I'm doing. I prefer to do them two approach. If I didn't lower the intraocular pressure by my first approach, I will go for another one. However, in other chronic narrow angle glaucoma, I can combine the lens surgery together with angle surgery in the very beginning.
Yeah, that's what I do. When you get deep anterior chamber after iridozonal highlighted vitrectomy and the lensectomy, you can go ahead and do angle surgery. That's what I do. And GAT is another perfect option in these cases. I have a couple of cases,
Sure.
in which I did GAT surgery after iridozonal highlighted vitrectomy, and it works very well. And you're working in a closed system, so it's very safe.
Yes, that's why I'm recommending not lowering the intraocular pressure, especially that you don't know a target pressure and you are having fallacious intraocular pressure with the thick cornea. So if you are not happy with the first intervention, you can proceed with angle surgery as a second step.
As a second option.
However, in other cases, in chronic narrow angle cases, not due to nanophthalmic eyes, I would go for both combined lens surgery and angle surgery at the same session.
Exactly, I agree. Thank you.
Thank you.
In those.
Sorry,
go ahead, Karim.
If the chamber remains shallow, as it often does after in nanophthalmic eyes, even if you implant a lens and so on, and if it remains shallow, to my mind, angle surgery would fail because the iris can go back up and get stuck. So you have to deepen the chamber somehow, be it by limited vitrectomy, as you described, or by cyclophotocoagulation.
Yes, I don't have experience with endocyclophotocoagulation, and I don't face any shallow anterior chamber if I do routine lens extraction plus the iridohyaloidectomy. And in the patient, in the female patient, I mentioned that I did for her total lensectomy vitrectomy. After discussing with the patient, the main concern of this patient was the glaucoma. That's why I left her aphakic. She was totally concerned about glaucoma. So doing total vitrectomy, lensectomy, put her in a nice condition, very deep anterior chamber, very deep angles, and the intraocular pressure got back very nice. And she was subjected to secondary artisan IOL, which didn't increase her intraocular pressure second time.
Just a small comment concerning angle surgery in those patients. You know, they have a very weird anatomy with the very thick sclera, and I wonder how is the anatomy of the collector's channel in those patients? You know, are those normal collector's channel, normal episcleral circulations? Like, what would be the success profile and the success rate of angle surgery, whether it's KDB or GAT, in patients who have such an anatomy, nanophthalmic patients?
Actually, Ziad, the three cases I mentioned in the termination of my presentation were not nanophthalmic eyes. I just recommended angle surgery as a technique to abandon any penetrating trabeculectomy. But I did, the only one in nanophthalmic eye was the 320-degree trabeculotomy under deep sclerectomy. I didn't perform the GAT in nanophthalmic eyes. But I think when I have a case which I didn't get intraocular pressure improved after the traditional lens surgery and pre-iridohyaloidectomy, I will try for the GAT. I hope the steep cornea and the small cornea will help me. I don't know.
Yeah, I have no experience with GAT in nanophthalmic patients. You know, when it comes, because I think it's, you know, it's a totally different ball game. But when it comes to chronic angle closure glaucoma, I think angle surgery is a great option. There's this great paper from Cyril Dorairaj that was published recently on the combination of phacoemulsification, goniosyncylisis, and Cahook dual blades. and they reported amazing results with this approach. You know, basically your phacoemulsification opens up your angle, goniosyncytialis to release, you know, the synechiae and exposing the trabecular meshwork, and adding the KDB to excise, you know, this thick trabecular tissue and opening up your outflow system. And this, I think, makes sense as an approach to chronic angle closure glaucoma. Mohamed, are you combining phaco to KDB and goniosyncytialis in patient with angle closure glaucoma?
So yes, angle closure glaucoma, I would do a, my standard approach is cataract extraction, goniosyncytialis, ECP. This is my trio. But if actually the PAS is extensive, and I don't have really a cutoff, like, you know, how much of the angle is really affected by the PAS, but I judge it. If it's long-standing and it's extensive, I don't bother, and I go for a combined phaco tube.
So why would you favor ECP over, let's say, KDB in such cases?
Because I feel that it's not only the internal limit of the Schlemm canal that is the issue. It's not only, I think that, like, you know, PAS and angle closure can affect your outflow in so many different ways that we don't understand. And if I'm inside the eye already, I would do the ECP, and it would actually help pull the iris backward as the processes kind of shrink. And it makes sense. I just haven't been doing that. I haven't been doing the combined Cahook with the goniosyncytialis. I think that goniosyncytialis would do the job if whatever angle function is still, remain.
Good point.
Can I make a comment on that? And Ziad touched on a great point, an angle surgery or GAT surgery in cases with non-ophthalmos. So this is a great point. So I'm now collecting data in those patients, because we really don't know the angle anatomy, the distal collector channels anatomy in those eyes. So I have a couple of patients. I did GAT, as I mentioned, right after the, once I get the large anterior chamber after the iridozonal hyaluronic vitrectomy in non-ophthalmic eyes. So I tried GAT in those patients to treat the chronic trabecular meshwork dysfunction and chronic glaucoma. And I tried to do GAT. And in a couple of patients, now I'm collecting data, in a couple of patients, it was really hard to thread the suture circumferentially. So there might be some maybe obstructions, I don't know what's happening in the canal. So it's hard to get it circumferential. It's hard to thread it circumferential in non-ophthalmic eyes. This is my clinical observation. But once you get half of the way, this is something. It's safe, but it's hard to make it circumferential in those eyes. As you said, we don't know the anatomy in these angles.
I just wanted to convey the message to our colleagues that I would not recommend penetrating trabeculectomy at any point during managing such cases. Also, I would not recommend placing devices, Ahmed valve or Molteno, and lens surgery is not enough also in such cases. So lens surgery, especially in glaucoma, already glaucomatous, is not enough. However, lens surgery might be enough in young patients seeking for refractive surgery, and as I mentioned, with certain precautions. Thank you.
Thank you. Thank you so much, Dr. Abdelhamid. Dr. Moustafa, you can unmute yourself as well if you want.
I was offline for a second there. Thank you very much, both of you, Mohamed, Zainab, and all of you, and Abdelhamid as well. That was very interesting. And now we move on and ask Dr. Mohamed to present his case of too short and too exposed. Please, Mohamed.
Can you see my screen?
Yeah.
Yes.
Okay, I have no financial disclosures. So I remember this case vividly, as it was one of the first cases that presented to me when I became an attending at Bascom Palmer. So then it was a 68-year-old female. I've known this patient for 2 years already. And she had a history of pathologic myopia. She was pseudophakic in both eyes, had lattice degeneration with multiple breaks, with a history of retinal detachment in both eyes that was repaired. The left eye had 3 retinal detachment surgeries. She also had very bad thyroid eye disease with severe exophthalmos that resulted in presumed compressive optic neuropathy that we were not sure of, because the patient also had glaucoma that was documented beforehand. She had undergone orbital decompression in both eyes, once only in the right eye, but twice in the left. She had a lateral tersorrhaphy in both eyes, but her eyelids were very friable. And in the right eye, she had the lateral tersorrhaphy repeated 3 times. Very bad trichiasis, was having a cryo treatment almost every month, and had a long history of primary open-angle glaucoma, or a mixed mechanism glaucoma, and had a trabeculectomy with mitomycin C in the left eye in the year 2001. In the left eye as well, she had a DSAC, anterior basement membrane dystrophy, and she had a severe ocular surface disease in both eyes, and she was monocular. Only the right eye was seeing. The left eye had a phthisis bulbi. The medications, she was on Travatan, Cosaptan, brimonidine in the right eye, and prednisolone and atropine in the left eye. The vision, no light perception with hypotenuse left eye. The right eye 20/60 despite all this, surprisingly, but the pressure was 32 on 4 molecules. The central corneal thickness was more or less normal in the right eye, thick in the left eye. On examination, the right eye, I'm going to focus on the right eye, had an extensive lateral tersorrhaphy. Actually, her fissure, her palpebral fissure was very small, barely actually exposing part of the cornea. The conjunctiva, when I asked her to look up and down, right and left, was very scarred from all previous retinal detachment surgeries. And inferiorly, the conjunctiva was completely adherent to the underlying sclera. The cornea was, a little bit hazy, acceptable, semi-clear centrally. But she had some sort of exposure despite all the despite the tersorrhaphy. She had punctate epithelial erosions extensively in the inferior half of the cornea, and but the gonioscopy was very difficult, by the way. Anterior chamber was apparently deep and quiet. The iris was okay, pseudophakic. The cup to disc ratio was 0.7 with mild pallor, and the macula was okay. So what should we do for this patient with a pressure of 32 monocular with all these comorbidities, ocular comorbidities? The options are basically trabeculectomy or cyclophotocoagulation, which can be micropulse or continuous wave, or a tube. Ziad, what would you do? You can unmute yourself, Ziad.
Yeah, so I think given the description that you gave, you know, the scarring of the conjunctiva and the severely altered ocular surface, you know, really compromises the chances of success of a trabeculectomy. So it's either a cyclophotocoagulation or a tube in that case. You know, the tube would be extremely challenging given the anatomy that you're working on, the fissure. I would probably go for cyclophotocoagulation as a first line with a slow burn if I cannot put a tube in. I think it's going to be very challenging to put a Barvelt in or an Ahmed in if the fissure is so narrow and the surface and the ocular surface so scarred.
Zainab, what would you do? You can't do GAT here. You can't see me.
Yeah, definitely. Yeah, I'm just forcing myself to look in other direction. But trabeculectomy is tricky, and tube surgery is also tricky in a patient with the conjunctival scars, and cyclophotocoagulation is like that. So, yeah, I can definitely I would check the angle first to do GAT. Yeah, I can do GAT, but among these options. I can, I would try cyclo first and then go for, if it doesn't work, I can go for tube surgery.
Okay, so that's what I did. So I chose to go for a CPC. Again, bear in mind, like, you know, this was like, you know, probably my first week in Bascom Palmer as an attending. I really didn't want to, like, you know, be all that heroic, and I just wanted to, like, you know, be under the radar. I just chose the least invasive option. So I went for a cyclophotocoagulation that is continuous wave with a slow burn setting. So I did 18 spots. The power was 1250 milliwatts, and the duration was 4 seconds, like Dr. Abdelhamid had described earlier. Post-operatively, day 1, the pressure was 22. I had the patient resume COSOPT, of course, in addition to, you know, 2-hourly steroid drops. At week 1, the pressure was, like, you know, slowly escalating. I had the patient at 26, I had the patient resume brimonidine as well. Week 4, the pressure is 44. So I decided to go for a second procedure. What would the second procedure be? Dr. Abdelhamid, what would you do? You're muted, so can you please unmute yourself?
I think I would like to keep the cyclophotocoagulation, even the slow coagulation technique, for the very last option, as a very last option. So I would start with a valve with good dissection, prepare myself with free conjunctival graft from the other eye if available, if he's one-eyed with amniotic membrane or graft. So I would prepare myself with ambient coverage for the conjunctiva.
Dr. Tomey, what would you do? Please unmute yourself.
You mean after
after the first CPC with a pressure of 44 after 4 weeks, monocular patient?
I guess your options are quite limited to either another session of cyclophotocoagulation, which can be risky, or a tube, as was said. But I'm not sure the conjunctiva would allow the proper dissection and closure to implant a tube. But certainly, if a tube can be implanted, maybe that's more predictable.
Okay, right. So I actually opted for another cyclophotocoagulation. I still wanted to remain under the radar, not, like, you know, no invasive surgeries at that point in a difficult patient. So I did another transscleral cyclophotocoagulation. I increased the number of spots, like, you know, the other settings remain similar. Day one, after the second CPC, the pressure was 30. I resumed both COSOPT and brimonidine in addition to 2 hourly steroids. At week one, the pressure was great. It was 16. I was very happy. I continued both COSOPT and brimonidine. Week 4, pressure slowly escalating, you know, 20 on all 3 drops. Week 6, pressure is 48. And I had to make the difficult decision to go for a third procedure. So the third procedure, like, you know, if I did another CPC and expect a different result, that would not be too smart. So I'm not gonna do a third CPC, I'm gonna go for a 2. So the 2 options are either a non-valve tube or a valve. So either a bar valve or an AMED. So the bar valve would give me better longevity and better control. And it's actually my prefer. I rarely use the AMEDs, but I prefer very much the bar valves. And now I also do the clear paths. But in that case, like, you know, the pressure was really high. The bar valve takes like 6 weeks to start functioning because, like, you know, you put in the ligature plus minus the intraluminal stent or ripcord suture. So I really wanted something to lower the pressure immediately. So I went for an AMED glaucoma valve to achieve early pressure reduction. But now, where would I place that valve? This is the difficult question. So we have 4 quadrants: superior temporal, infranasal, superior nasal, infratemporal. So superior temporally, the axis was very difficult because of the lateral tersorrhaphy. Infranasally, like, there was severe scarring. Infratemporally, it was both severe scarring and difficult axis. So I was left with only superior nasal quadrant as the only option. So this is what I did, and I chose the superior nasal quadrant for AGV implantation. Postoperatively, day 1, the pressure was 13. I started the patient on dorzolamide, and this is my routine when I put in an AMED to minimize the chance of a hypertensive phase. So I start patients with a pressure higher than 10 on an aqueous suppressant, typically a carbonic anhydrase inhibitor, on day 1. On day 7, the pressure was 9. I was very happy. The patient was very happy as well. Pressure started escalating. So at month 1, the pressure was 19. I switched the dorzolamide to COSOPT. At month 2, the pressure was 36. And I did a very difficult gonioscopy to find, I couldn't see the tube. I really, like, I was able to see the tube prior to, like in previous visits, but I couldn't really visualize it in the anterior chamber anymore. And I do a gonioscopy and I see that actually the tip of the tube is embedded in the angle structures. I can hardly see it or recognize that there's something that's completely clogged. And by asking the patient to look downward, like, you know, I see this, like, you know, exposure as well. So I decided to go for a 4th procedure. And this was the procedure. I place in here I'm gonna pause for a second. So you see the temporal tersorrhaphy, you see like where all the eyelashes are, and like, you know, this is actually the pediatric size speculum. I couldn't fit in a regular size speculum. This is like actually the neonatal speculum, if you want. And,
just a question here, Mohamed. What the shape of the pupil seems not to be irregular. Am I seeing this
right?
correctly?
And I don't know why. And I wrote that the pupil, like, if I go back to the exam slide, I wrote that it's a surgical pupil. Like, you know, I think it's probably a difficult cataract surgery or something. I'm not 100% sure. But you see here all the conjunctivalization of the cornea and all that. But again, like we see the tarsorrhaphy here, and I actually spoke with Dr. David C., the professor of oculoplastic surgery. I told him, can we cut the tarsorrhaphy? And he said, please don't. Please just work around it. This patient has very friable tissue, eyelid tissue, and it would be very difficult to do the tarsorrhaphy again. So I placed the 7/0 vicryl traction suture. And here, like, we can see that the tube is exposed, and I try to actually open the conjunctiva, and it was like that even like, the first time when I did the tube, it was very difficult. And you can see how, like, it's like completely adherent to the underlying sclera for like, a couple millimeters behind the cornea. And we see the exposed tube. Key here is to try to undermine the conjunctiva as much as possible. So you want to, have to relax all these adhesions. And I removed the tube. I injected viscoelastic through the sclerostomy, and I closed the sclerostomy with a 7/0 vicryl in a figure of 8 fashion to make sure that, the sclerostomy is well closed. And one reason we do close the initial sclerostomy is because if a patient has, a tube has exposed, it will continue to expose every single time you revise it, but leave it in the same place. You need to change the microenvironment of a tube in order to avoid re-exposure. So the sclerostomy is being closed here. And we see how, like, very, very thick ocular surface. And I'm trying to, like, create as much, like, space and have as much conjunctiva to work with. And I'm cutting all the adhesions, severe adhesions between the conj and the sclera. And again, I'm trying to mobilize the conjunctiva to see, like, how I'm gonna cover my tube. And then I decide to cut the tube off because it was too short, and then connect it to a tube extender. This is an Ahmed tube extender. So this goes in. You may actually leave it as is, like I did here, or actually fix it with a nylon suture, an 8/0 nylon. Now, this is an 8/0 nylon in the, here, I'm directing the tube away. I'm directing it to the superior temporal quadrant. And I'm placing the 8/0 nylon suture to fix the extender to the sclera and the other eyelid as well. And now I'm making a completely new sclerostomy using a 23 gauge needle. And I'm tucking in the tube in the eye. Now, how am I gonna cover this? So I chose to cover it with a 2+ pericardium patch graft. I sutured that to the underlying sclera with a 7/0 vicryl. Everything was difficult. I was already past 1 hour, or like 1 hour, 15 minutes at that point in surgery. So I fixed that to the sclera, covered the extender very well, and covered the tube. I stopped using the tube extender, and I now use a different technique, which we can talk about later. But so here, I think that, like, both are very well covered by the pericardium patch graft. Now, like, again, will the conjunctiva be mobilized enough to cover all this or not? It's like, all my sutures keep cheese wiring. I kept placing series of mattress sutures, horizontal mattress sutures. And I take scleral bites at the limbus. And finally, I was able, I'm gonna actually fast forward a little bit because the closure is gonna take a long time. The closure took like, you know, an hour by itself. But I was happy that, you know, I was able to close it. It looked great at the end. I was very, very happy with myself at that point. And okay, the postoperative pressure, day 1, the pressure was 7. Day 7, the pressure was 9. 1 month after the surgery, the pressure was 13 on no medications. 4 months, the pressure was 12. And this is the last time I saw the patient. The last time I spoke with one of my colleagues in Bascom Palmer who took over the care of the patient told me that the pressure remains in the low teens, and I'm quite happy. Thank you so much.
Thank you, Mohamed. That was great. That's a really tough case. Any comments, guys, before we go?
Didn't you try when you, if you remember the case of abexterno 320-degree trabeculotomy under deep sclerectomy? When I was dissecting the sclera, it was very hard and it was very much fibrotic. And after relieving the deep flap and uncovering the trabeculodescent membrane and finding no seepage, I was happy, because depending on any seepage or any conjunctiva in such condition will fail. So I proceeded to 360-degree sclerotomy or 320, as I mentioned. So what I want to say that even in such fibrotic sclera and such fibrotic conjunctiva, you can still through the deep sclerectomy, you can find your way to an intact canal of Schlemm. This is number 1. Number 2, in a lot of cases where I do the Ahmed valve, I rely upon using free conjunctival graft instead of doing this tough work you have went through. This is my 2 comments. Thank you.
Thank you so much. So just commenting about the conjunctiva and how it was really attached to the sclera. So this is like, you know, the surgery that I didn't show, the initial implantation of the Ahmed valve. So I actually couldn't cut with, you know, my blunt Westcott scissors, and I had to actually use initially the Vannis scissor to cut through. And it was very difficult. So I actually also used a 75 blade to cut the conjunctiva. So I really don't know whether, like, you know, trying to make a scleral dissection and all, like, you know, this severe scarring I would get anywhere. However, here, like, you know, really we have a very low threshold for using tubes, and this has been the subject of debate over the past few weeks in all the glaucoma webinars on, like, you know, the preferred glaucoma procedure. I always go for a tube. I do primary tubes. I have no issues with primary tubes, but this was like a case that was really different and just unlike, like, you know, the other routine cases that I usually do. Ziad, do you have a comment? You're muted.
I have a couple of comments. Oh, sorry, Ziad, go ahead.
Yeah, so I was saying that that's a nightmare case, and you did an amazing job on that one. I'm not using any of those, you know, tube extenders or pars plana clips because they tend to erode like crazy. And I think you alluded to that. I think you're doing the tube and tube. Tube.
That's what I do now. Exactly. So I just use a curved McPherson to like, you know, actually make open it up and just tuck the second tube in, and it's much easier and it's much less bulky. And
Just one question. You know, when you dissected the conch and you removed your tube from the anterior chamber, did you consider at a certain point, you know, flushing the tube just to?
I did do that. It's just not shown in the video.
Oh, okay, great. So it's an excellent case that it's like really well managed. Impressive case, Mohamed. Thank you for presenting that.
Thank you.
Karim, you had a couple of comments.
Yeah, the first one was about the tube extender, but you covered that. The other thing is, in these stubborn cases, it becomes justifiable to use even systemic carbonic anhydrase inhibitors, and you may not need to go to very high doses. You know, we have gotten away quite often with doses as low as a quarter of a tablet twice daily, and that doesn't give a lot of side effects, and it may work quite well. I certainly, luckily, you know, this patient ended up being controlled, but if the pressure goes up again, then I wouldn't go to another cyclodestructive procedure, and there is certainly no room for another tube. So a low dose of Diamox may be well justified and may work.
This is an excellent case, Mohamed.
Thank you, Zainab.
And you did a great job. You know, tough case, bad ocular surface. You cannot see the angle, it's scarred conjunctiva. You don't have the space to put the tube in. It's a great job. Thanks for the case. So I might do maybe, I would think to perform an ab externa surgery like mentioned before. Yeah, thank you.
Thanks, Dr. Moustafa. All right, so I think Dr. Moustafa is having issues.
We need to round this up. Adil from. Hello?
Yes, Dr. Moustafa, we can hear you.
I lost. I'm muted. Hi. I thank you everybody for this wonderful. I think we raised more. I think Dr. Moustafa Adil would like to tell us, would like to talk to us for a few moments. Dr. Moustafa.
Okay. Thanks, Dr. Moustafa, and thanks for all our professors for the great lecture of today. We learned so much from it. Briefly, we are talking about our products. As a Pharma Medica, we have Pharma Press as a bromidine tartrate 0.2% as an anti-glaucoma. We have Pharma Timogan, fixed combination between bromidine tartrate 0.2% plus timolol maleate 0.5% as an anti-glaucoma. We have Pharmastine as a epinestin hydrochloride as an anti-allergic. We have Pharmabrid as prednisone acetate 1% corticosteroid. We have Pharmagatine as a gatifloxin 0.3 fourth generation fluoroquinolone antibiotic. We have Pharmatirs as a carboxymethyl cellulose 0.5% as an artificial tear. Thank you very much, our professors, for the great meeting.
Thank you, and thank you everybody for attending this. I think we may have to gather again sometime later in the future. The questions are still coming in, and we need to answer some of them. So maybe another webinar. Thank you very much indeed. That was a wonderful job. Thank you, everybody.
Not so late, please.
No, not so late. I hope so. It's too late for me to. Thank you. And sorry, Mohamed, congratulations for your wife. And we hope you can catch the rest of the celebrations. Thank you, and congratulations for her. Thank you.
That was great.
You.
Thank you.
Thanks, everybody.
Thank you.
Thank you so much.
Thank you.
Thanks, everyone.
Thank you.
Thank you. Bye.
Bye-bye. Bye.